Welcome, MRCOG candidates. I am absolutely thrilled you're joining us for this explainer today. We are going to be dissecting a seriously high-yield, complex, and just absolutely vital topic for both your exams and your everyday clinical practice: blood transfusion in obstetrics. We're going to master the thresholds, the protocols, and all those critical decision-making pathways you really need to know. So get focused, maybe grab a coffee, and let's conquer this together.
Okay, so what you are looking at right here is the definitive, canonical source material. It's the official RCOG Green-top Guideline No. 47. This is your ultimate rulebook, guys. Mastering the evidence-based recommendations in this document, it's not just about passing an exam, although that's obviously important. It is really about providing safe, life-saving care on the delivery suite. Whenever you feel kind of overwhelmed by all the moving parts of a major bleed, this is exactly the protocol you're going to fall back on. Here is our roadmap for today. First, preventing transfusion. Second, principles and preparation. Third, major hemorrhage protocols. Fourth, blood-sparing adjuncts. And finally, number 5, refusal of blood products. Let's start with Section 1, Preventing Transfusion, Antenatal Anemia. Now, knowing the exact diagnostic criteria for anemia is, well, it's classic MRCOG test fodder. Anemia in pregnancy isn't just one flat number that applies across the board. It's defined by very specific hemoglobin cutoffs that actually change depending on the trimester and the postpartum period. And this is entirely in line with the British Committee for Standards in Hematology guidance.
You really need to burn these exact numbers into your memory: 110, 105, and 100 grams per liter. So if a patient's hemoglobin drops below 110 in the first trimester, 105 in the second or third trimester, or 100 in the postpartum period, they are officially anemic. These 3 critical figures are your triggers. They should immediately prompt you to consider hematonic deficiency and get a solid management plan going.
And once you've made that diagnosis for normocytic or microcytic anemia, you follow this tiered intervention model. Step 1 is always a trial of oral iron. That is definitively your first-line treatment. But don't just prescribe it and forget about it, right? Step 2 means you have to check their compliance and retest it 2 weeks to look for a real, demonstrable rise in hemoglobin. Then there's Step 3. Transitioning to parenteral or intravenous iron is strictly indicated for when oral iron just isn't tolerated, maybe it isn't being absorbed, if you highly doubt patient compliance, or, crucially, if the woman is fast approaching term and you literally just don't have enough time for oral supplements to do their job.
Moving right along to Section 2, Transfusion Principles and Preparation.
So, the absolute key point here is mastering the 3-day rule. We know all women get their group and antibody status checked at booking and at 28 weeks. But if a patient has been transfused or pregnant within the preceding 3 months, any sample you use for cross-matching absolutely must be less than 3 days old. We do this to ensure we catch any new, unexpected antibodies from a secondary immune response. Now, what if you have a patient sitting on the ward at a really high risk for an emergency transfusion? Say, someone with placenta previa, but they don't have any significant antibodies. Well, the guideline recommends sending a sample once a week, just to make sure blood is readily available if things go south.
When we get down to actually specifying the blood products, there is a massive pitfall you've got to avoid. Yes, obviously we transfuse ABO and rhesus D-compatible units, but you must also ensure the units are KEL-compatible. In fact, only KEL-negative blood should be used for women of childbearing age, unless they are already known to be KEL-positive. Why is this so strict? Because previous transfusions can cause alloimmunization with anti-K antibodies, and that leads directly to severe hemolytic disease of the fetus and newborn. You definitely want to avoid that.
There's also a really vital difference between elective and emergency scenarios when we talk about cytomegalovirus or CMV. For elective transfusions in pregnancy, you should provide CMV seronegative red cells and platelets. However, in a life-threatening emergency, you never ever delay for a CMV negative unit. Standard leukocyte-depleted components are perfectly acceptable to save a life without wasting precious time.
All right, into Section 3, Major Obstetric Hemorrhage Protocols.
Picture this. You're in an extreme situation. A patient is bleeding out rapidly, and you do not know her blood group. What's your move? You do not wait for a cross-match. No way. You immediately issue Group O, rhesus D-negative, and KEL-negative red cell units. This is your authoritative, first-line directive for securing uncross-matched blood safely in a crisis.
When replacing specific blood components during a hemorrhage, you have to lock down 3 distinct targets. We have fresh frozen plasma, driven by coagulation screen ratios, cryoprecipitate, driven by low fibrinogen, and platelets,
driven by the platelet count itself. This table is basically your cheat sheet. Let's break these down a bit more specifically.
For fresh frozen plasma, or FFP, the protocol dictates a dose of 12 to 15 milliliters per kilogram for every 6 units of red cells you administer. Your goal here, your absolute target, is to keep the PT and APTT ratios below 1.5 times normal. Now, to actually do this, you absolutely must perform regular full blood counts and coagulation screens during the bleeding episode. Seriously, you are flying completely blind otherwise.
Let's go back to that actively bleeding patient. You've already replaced 2 whole blood volumes. At this point, you can pretty much anticipate that their platelets and fibrinogen are totally tanking. Your platelet trigger to transfuse is 75, with the strict aim to maintain them above 50, which, as you know, is the critical level for hemostasis. For fibrinogen, levels drop unbelievably fast in severe postpartum hemorrhage. You need to administer 2 5-unit pools of cryoprecipitate early on, aiming to maintain fibrinogen above 1.5 grams per liter. Really try to anchor these exact numbers in your head for the exam. They love asking about this.
Section 4. Sparing blood and pharmacological adjuncts.
So, intraoperative cell salvage, or IOCS, is highly recommended. It filters amniotic fluid beautifully. But here's the catch. It will not filter out fetal red cells. So if you use IOCS during a cesarean in a rhesus D-negative woman, you're actually reinfusing potential rhesus D-positive fetal cells right back into her circulation. Because of this, Step 2 dictates you must administer a minimum dose of 1,500 international units of anti-D following the reinfusion. And Step 3, you have to check a maternal Kleihauer test exactly 30 to 40 minutes post-reinfusion to see if even more anti-D is indicated. This whole sequence is highly testable.
That brings us to the pharmacological heavy hitters. Think about this for a second. When exactly should recombinant factor 7A be used in obstetric hemorrhage? Is it your ultimate silver bullet when things look grim?
The decisive answer is absolutely not. While it may be considered for life-threatening postpartum hemorrhage, it absolutely must not delay or substitute your life-saving mechanical procedures. Things like interventional radiology embolization, surgery, or transferring the patient, they take absolute precedence. Remember, using RFVIA off-labels carries a very real, significant risk of arterial thrombosis. It's a last resort option that you discuss with hematologists, definitely not a quick substitute for surgical control.
And when we compare 2 other common pharmacological agents, look at the completely differing levels of evidence. Tranexamic acid, an antifibrinolytic, is broadly recommended. You should be considering it for all major obstetric hemorrhage, and that's backed by massive trials like CRASH-2. On the other hand, fibrinogen concentrate. It's actually not licensed for acquired bleeding disorders in the UK. Therefore, the guideline clearly states its use in PPH should only be considered strictly within the context of clinical trials.
Finally, Section 5. Managing refusal of blood products.
Managing patients who refuse blood, such as Jehovah's Witnesses, requires exceptionally stringent preoperative planning. You've got to have multidisciplinary input early on. Your absolute paramount goal here is to optimize their hemoglobin to the maximum before delivery to prevent any avoidable anemia. You must discuss alternative strategies like cell salvage and intravenous iron early, and ensure an advance directive is clearly documented in their notes detailing exactly what components or techniques they will and will not accept.
There's also a vital ethical obligation we have to touch on here. The guidelines clearly dictate the woman should have an opportunity to discuss consent alone, witnessed with an experienced clinician, to avoid any possibility of coercion. This really highlights the utmost importance of sensitive, confidential communication when you're dealing with advanced directives and consent. You have to ensure she fully understands the maternal mortality risks, but you absolutely must do so in a safe, unpressured environment.
Wow, okay, we've covered a tremendous amount of ground today. From the 3-day rule and specific hemoglobin cutoffs, to exact FFP and cryoprecipitate triggers, right down to the strict rules on cell salvage and anti-D. So my final question to you is this: how will mastering these precise clinical triggers change your decision-making on your very next delivery suite shift? Will you be the one who confidently calls for K-negative emergency blood when the pressure is on? I know for sure you will. Keep studying, keep trusting the guidelines, and I will see you in the next explainer.